A very warm welcome, everyone. This is SM Abdullah, a member in Health Economics Research Network and fellow in ARC Foundation. I appreciate all your kind presence despite the busy schedule. On the capacity building front, under the umbrella of HERN, this is the regular webinar that we arrange to develop the network and collaboration. And we usually do it in support with the Center of Health Economics, University of York, UK. Today, we have the honor of presence of Dr. Naomi Gibbs as a speaker. Dr. Naomi is a research fellow currently in the Center of Health Economics in the University of York. She completed her PhD in Public Health and Economic Decision Science from the University of Sheffield. Naomi's PhD focused mainly on decision modeling to appraise cost and health outcomes of a hypothetical minimum unit pricing policy for alcohol in South Africa. She devoted her research on the economic evaluation of health policy in low and middle income countries. Dr. Naomi also works with stakeholder engagement to improve relevance, quality, and communication of research. Today, in her presentation, Dr. Naomi will reflect on how her public health economic model of minimum unit pricing of alcohol in South Africa benefited from and was shaped by stakeholders. She will outline how engagement activities were used during the development, validation, and communication phases of the research, with input gathered at each stage to inform further priorities. So without further ado, I would like to welcome Dr. Naomi Gibbs to provide her presentation. Over to you, Dr. Naomi.
Thanks for that introduction, Abdullah, and hello, everybody. It's really lovely to be able to present to you today. I hope this session can be useful for everybody in some way. And I'm going to present my experience of stakeholder engagement. And as Abdullah said, there'll be time for questions at the end and comments. And I'd be really interested to hear from you about your experience, perhaps, of stakeholder engagement. I'm aware there might be a lot more expertise sort of on the Zoom call. It'd be great to hear about. This work was work I did during my PhD at Sheffield University. And it's stakeholder engagement in the development of public health economic models. And I'm going to talk about alcohol modelling in South Africa as a case study for that. So if you find anything interesting from this presentation, it is written up in an academic paper published in Applied Health Economics and Health Policy. And I'm happy to share the slides afterwards, and you can use this link. So if there's anything you'd like to go back to, you'll be able to do that. So my presentation is going to follow this outline. So I'm going to start by explaining a little bit about the policy context. So just a tiny bit about alcohol and minimum unit pricing in South Africa, so that the example and the engagement sort of becomes a bit more understandable. I'm going to talk about how this sort of thing could be relevant to Bangladesh, or how it might not be relevant. And then I'm going to talk about the stakeholder engagement. So who did I engage? And then how did I do that engagement? I'm going to then move on to list some of the outputs that resulted from the engagement, talk a little bit about the national versus regional approach to stakeholder engagement, and then I'm going to finish with some top tips and a bit of a summary. The context then, alcohol in South Africa. There are very high reported levels of abstention, so no drinking in South Africa. 82% of women and 46% of men report that they don't drink at all. However, this is combined with very high levels of heavy episodic drinking, which is binge drinking. So that's drinking more than 5 drinks on one occasion. So drinking sort of to get drunk. Beer is the most popular drink, and it's often sold in quite big bottles. In the UK, we have smaller beer bottles, but in South Africa, they sell them in bottles that are 750 millilitres. And the prevalence of drinking increases with wealth. So if you're richer, you're more likely to be a drinker. But there's an inverse relationship with harm. So if you're richer, you're also likely to be harmed less by the same amount of alcohol consumption as somebody from a poorer group. Okay, so alcohol's a problem in South Africa. There's lots of alcohol harm. There's lots of binge drinking. One of the policy options, and one recommended by the WHO, is minimum unit pricing. And so that policy is where a retail floor price is set, which depends on the alcohol content of the drink. So basically it means when the drinker, the consumer, goes into a supermarket or any sort of shop that sells alcohol, or a restaurant, they can't buy alcohol for less than a specified price, depending on the alcohol content. And the rationale for this policy is that minimum unit pricing targets the cheapest alcohol, which is drunk by the heaviest drinkers. And so this will have a greater impact than a price increase across the distribution. So often when we think of unhealthy commodities, we might think of taxation and we might think, let's just increase the tax. That's going to affect all prices. And actually, the people who are suffering the most are the ones drinking the cheap alcohol. So we might want to affect those prices more. So that's a tiny little overview of the context and the policy. But I wanted to just sort of think about the relevance to Bangladesh. So looking at the Global Status Report on Alcohol and Health, in South Africa, the litres of alcohol consumed per capita are 9.3 litres per year. In Bangladesh, 0.0. In South Africa, abstainers, so people reporting to be non-drinkers, are 69%. In Bangladesh, nearer 98%. So a public health policy professional or a health economist, when looking at improving population health in Bangladesh, is unlikely to be looking at alcohol policies. However, what about other commodities? What about sugar and salt? Other commodities that might have negative health impacts and have the potential for a pricing policy intervention. So I think these lessons and the example I'm going to share with you would translate quite well to other commodities that you could use pricing policies for. I did, in preparation for today, I did a quick search about Bangladesh, focused on Bangladesh, and saw just very briefly this really interesting paper published this year on geospatial variation in dietary patterns and their association with heart disease in Bangladeshi population. And I'm not going to spend ages on this, I just think it's a useful little example. So the paper identified 3 major dietary patterns using a cross-sectional survey: a festival pattern, pickles and fast foods pattern, and a rice and vegetable pattern. And they found that areas with the highest adherence to rice and vegetable pattern also had the lower rates of heart disease. So why am I sort of mentioning this? It's just because I want to help put my research in perhaps a policy context that's more useful and relevant. And there would be parallels with alcohol policies. So one of these is industry behaviour. Industry generally doesn't enjoy regulation, certainly the case with alcohol in South Africa. And also price regulation as a policy option for population health. You know, this can apply to lots of different things. Also, I think what's one thing that I wanted to talk about today is this possibility for a regional approach. So sometimes health policy applies at a national level, and that's great, but sometimes it can be more regionally focused, and that might impact who you engage and the types of policies that you're able to look at. So that's sort of setting the scene a little bit, I hope, both of my research in South Africa, but perhaps how it could be translated to Bangladesh. But that might be rubbish and I might have completely missed the point, but you might have your own thoughts on that. It'd be great to hear about it later. So now I'm going to focus on sort of my stakeholder engagement, who I engaged and how I engaged them. So I engaged with what I saw as 3 categories of stakeholders. The first of these was policy. So I wanted the research to be useful to policymakers. And I was able to speak to people from the national government in South Africa and then also the provincial government. So there are 9 provinces in South Africa, which I think probably corresponds to the 8 divisions of Bangladesh. And my supervisor in South Africa was based in the Western Cape. So we engaged quite a bit with the Western Cape government, people who create the policy, but also the Western Cape Liquor Authority, who would have had responsibility for any pricing regulations. The second category was civil society organisations. Now, these might be called different things in different contexts, but they are essentially community groups or charities or sort of advocacy groups who cared about alcohol harm and pricing and the industry. So there was the South African Alcohol Policy Alliance, who particularly sort of campaigned on alcohol harms. The Douglas Murray Trust were an organisation that funded research in South Africa. The Kailicha Community Health Forum were brilliant. It was a group of individuals, it was mainly women that I worked with, that lived in informal settlements outside of Cape Town. So these were areas where there was lots of unregulated alcohol, and they would be able to hold us to account as we're doing the research and tell us what alcohol harm they experience, also what prices they can pay for drinks in sort of unregulated, what are called shebeens within South Africa. So that was really helpful to ground our research in reality. And finally, within civil society organisations was violence protection through urban upgrading, and they were interested in licensing, which again was a really important policy issue. My final category of stakeholders was academics. So I wanted to make sure I was engaging, not treading on anybody's toes, as I was a researcher that wasn't living in South Africa, but also that my research built on all the excellent research that had gone before. So I engaged with people from the University of Cape Town, the South African Medical Research Council, where my supervisor was based, and also the University of the Western Cape. So there are other categories of stakeholders that you might want to engage in your health economics research, but these were the three that we felt gave enough context and were going to be perhaps end users of the research. So I sort of ended up thinking about the stakeholder engagement in 4 distinct phases, and I'm going to sort of start and end my presentation with these 4 phases. So the first one is to develop a detailed understanding of the local policy context. This was particularly important for me as somebody not based in South Africa. But I actually think whoever you are, wherever you're based, it's really important to understand the context outside of your own personal experience as well, and talk to as many people as you can. The second phase was to co-produce the model, focus and structure. So I'll talk in more detail about that one on the next slide. The third was scrutinizing model development and planning communication. So this meant that I didn't just talk to people at the beginning and then show them the research at the end, but there was an intermediate step where I was holding myself and my research to account, and people were really helpfully inputting as it was being developed. And the final phase was communicating the research evidence to the end users. So my overall aim was estimating how pricing policies could reduce alcohol harm and which population groups are affected most, using a health economic model. So that's my sort of overriding aim of the research. And I had a timeline which slightly went out the window. COVID happened and various other things, but it was roughly around this time, but we won't worry too much about that. So stage 1, sort of phase 1, developing a detailed understanding of the local policy context. I started with interviews. I had 12 or 14, I can't remember, semi-structured interviews with stakeholders from those 3 groups, so from policy, civil society, and academic institutions. And the idea for those interviews were to really capture the views on alcohol harm. So what harm do people talk about in South Africa? You know, if you created an economic model and it missed out HIV, you know, does that undermine its credibility? What's the most important? You've got to include those things. I also talked about what pricing policies exist and sort of tried to gauge what was already known about, what evidence was already available and what was high profile. And then we also talked a little bit broadly about equity. I mentioned in the first slide that poorer drinkers were harmed more, and I wanted to try and bring this through in the research. And so it was important, again, to understand, particularly in a country like South Africa, how is equity understood? What groups are most oppressed by the societal structures they live in? How can we capture that, and what's important? So really kept it quite open, and it was incredibly useful. That allowed me to sort of go away, think about this, and explore some data sets, start getting a sense of what data is available to me, what sort of modelling I might do, and planning the first workshop, which was in order to co-produce the model, focus and structure, now having some understanding of the context, which I didn't have before the interviews. So workshop 1 was in South Africa. It was an incredibly interactive session. I made sure I mixed people up. It was great to be there in person. And what we did was we produced a conceptual map of the problem of alcohol in South Africa. People literally went away and drew on it. wrote on it and sort of mapped out what they thought was going on, brought it back together and talked about it. We then talked about the policy options, what pricing policies are available, what already is going on in South Africa. And as a group, they chose what policy they wanted me to model. We then talked about subgroups. So that thing about equity, who do we care about? Making sure we don't sort of hide the impact on them that might be different from the impact on other people. And outcomes. So we want to include costs. What about productivity? What about which health outcomes are the most important? Pragmatically, you can't do everything. So getting a steer on all of that was really helpful. So again, I went back to my computer, to my data sets and my model building and learning the software. I sort of spent quite a few months doing that. And then it was into the sort of scrutinizing model development phase and communication planning, which was workshop 2. So at this workshop, I discussed model progress, and that was incredibly useful because I was starting to have to make decisions such as, if the price goes up on this product, do people switch to illegal sources of alcohol? What would people think? How much? What price? So assumptions like that within the model I could take to my stakeholders. But also things like validity of the data sources. So the academics were challenging my use of some data and providing different sources. I could then scrutinize that and talk to them and argue back and forth and really get that validity for what I was doing. It's really helpful. And in this session also, we discussed who we might want to present these model results to and how. So who are we going to invite, how are we going to present the information, and create a bit of a plan, because again, I didn't know who was the most useful. Again, went away, did more model building by myself, and then the final stage, so this is about communicating results. So I presented the results at a sort of a workshop, a presentation, the final results, and I made sure that I asked 3 of the stakeholders who had been with me right from the interviews to give a 5-minute reflection on the research and what they thought was important and what they thought the next steps were. And I chose one person from each of those 3 stakeholder categories just to get that breadth of view on the work. So that's broadly how I engaged stakeholders during the development of my public health economic model. Now I'm going to just highlight a few of the outputs, not the actual research. You can look at that if you want to, but the outputs that came about because of the engagement. So one of the things that my stakeholders were really keen on was a policy brief, a 1-page policy brief. Don't try to read it. I'm just sort of showing it to you here as an example. It basically highlighted the problem, the policy, and what we estimated the outcomes could be of the policy. And that was important for accessibility, communicating to an audience outside of academia. Other outputs, I was commissioned to tailor the national model, so the national research, to a provincial level. So that's one of the 9 provinces of South Africa. And that was largely because of our engagement with the local government. I presented the results to the Premier of the Western Cape, which is sort of like the head politician of that province. And I was asked to contribute reports to a policy consultation process for minimum unit pricing. So they decided they wanted to go ahead with it, and they launched a public policy consultation process. I was then asked to attend these public consultation events and answer questions on the research. They did say they were passing it. I don't believe it's been implemented yet, which unfortunately does happen quite a lot in South Africa, according to my supervisor. In addition, I was interviewed on the radio in a sort of a radio program that's interested in research for South Africa. I just wanted to mention here sort of national versus regional engagement. So my work focused nationally on South Africa, but as I mentioned, we had quite a lot of engagement from one particular province, and that then led on to further engagement with them. And depending on your policy, so minimum unit pricing can be implemented at a regional level. Local governments can take it up rather than it being a national thing, although it's better if it's national. But sort of just thinking about that, sometimes it's really useful to have a mix of national and provincial decision makers depending on what your sort of health economics research question is. And I was thinking about this for Bangladesh. I think they're There's 8 divisions. I'm not sure on the powers of the different areas, but going back to that sort of research on the geospatial variation in dietary patterns, maybe different regions, particularly ones with high levels of heart disease, would be interested in particular sort of food policies or regulation around salt and sugar or unhealthy foods that you could, if you were interested in that sort of research, you would then go and find what powers they had and what questions they were asking, what policies they were interested in. Just something to think about. So I thought just sort of 4 top tips from my experience. You might have your own experience with this. So the first one, and I know this can be quite tricky. I was really lucky because I had funding for a PhD and I could pretty much do what I wanted within public health, economic decision science. So I had a lot of flexibility in my research question. I know sometimes you don't have as much flexibility because you're answering to a funder and it's all been really laid out. But I guess for that, the earlier you engage stakeholders, the better. But if you can be flexible in your research question, great, because often there's a policy window and it's small. And if you don't get in there, then you get less impact, less interest and engagement. Secondly, and apologies, this seems probably with this, but building a reputation for reliability. So I just made sure that whatever I said I would do, I did. And when they gave me feedback or input, I would always make sure at the following session, I would reflect on it and I would say, last time you told me this and I did this, so that so we built that trust. Sorry, that's this point actually. Keep showing people how their input has shaped what you were doing. So as an example, the people I worked with really cared about including the unregulated market. So they said that's important. I asked them sort of more parameters around that, and then we made sure it was included in the model. So then when people challenge that part of the model, we can say, this is what we've done, this is what the stakeholders felt was reasonable, and we've made an effort with that. And my final top tip was about engaging with a broad range of stakeholders. It really enriches your research and improves credibility to policymakers. So it was great for us to have somebody that works for the National Treasury sitting alongside somebody who lives in an informal settlement. And actually, as a researcher, you have an opportunity to bring people together from quite different sort of worlds, I suppose, with different viewpoints. And that is a real privilege, and it's very generous of them to share their time and expertise with you as a researcher. But it's also a really positive impact that you can make as a researcher, and people will respect you more if you've heard from a wide range of voices, in my experience. So just gonna sort of recap, this is how I sort of think about and structure stakeholder engagement in health economics. So number 1, developing that detailed understanding of the local policy context. So where does your research fit in the world? Number 2, co-producing the model focus and structure. So allowing your research to be really shaped as much as possible by those you're speaking with. Number 3, opening yourself up to scrutiny. So getting people to scrutinize model development, and the challenge of communicating the health economics modeling conceptually from a data point of view is really helpful. And planning your communication, which again is going to need to be locally tailored. And number 4, communicating research evidence to end users and seeing that really as a team effort. So it's not only you that owns this research, it's not only you that has shaped it, but all of your stakeholders as well. And that can really come through in your how you communicate your end research. So I think, that's my presentation for today. I hope that gives enough of an idea of what I was doing, and I'd be really happy to welcome questions or have any comments and hear about your experiences.
Thank you, Naomi. Thanks a lot for your, spontaneous and, very specific presentation. I believe those who are working in the field of public health, they will realize the importance of stakeholder engagement and how, from a grassroots level, to do a contextualized research and how important the stakeholder engagement is and how to frame the stakeholders to implement the research. So now the floor is open. I would like to request our participants to ask the questions, and If you want to come forward, you can just raise your hand and unmute yourself. Or if you want, the chat box is open as well. You can write the question there. And Naomi, would you like to address one by one, or you would like to take few questions together and then go ahead?
I think one by one might help me because otherwise I forget to.
In the chat box, we have Syed Mortuza from Afghanistan. He doesn't have any question, just he appreciate your presentation. We have another question from Amna Babar, and she's saying that if you could please talk about some of the challenges or tips for tapping into the network of stakeholders as the very first step, particularly with reference to research priorities for policymakers in South Asia.
Yeah, great question. So right at the sort of start, I did a bit of desk research. I did a mapping exercise. I followed a framework. It's in the paper. I can't remember the reference now, but I tried to map out all the stakeholders who might be interested in alcohol. So that was much broader than who I ended up looking at. So it included industry, the police, drinkers, addiction services, all sorts of things, just to really try and expand my thinking. And then I took that map to local sort of academics who'd worked in alcohol in South Africa for 26 years and had worked really closely with policymakers. So that was the first step, was just identifying everybody who could possibly be interested. And then it was about having a chat with the research team about what purpose do we want this research to fulfill, and what pragmatically is going to make that possible. So do we want to invite industry, or is that, in the end, we felt that was too complicated because then we would be managing really diverse interests and the workshop would become more about that than about sort of the research question and providing something that's useful to policymakers. So in terms of actually stepping in to the network, I had a really good supervisor called Charles, who, as I say, had been an expert and worked in alcohol policy in South Africa for 26 years. So I started with him, and then he recommended a few people. And then every time I interviewed people, I said, who else is important? Who else can I speak to? And then I'd start to hear some other names, and I'd be able to contact them or interview them. For the policymakers, it was really interesting because it was difficult. It was difficult for me to get the national government involved, and we had to do it quite formally in the end. We had to pay for flights and all of that sort of thing. I'm not sure how. I really don't know the context in South Asia, so I don't know how you would start to engage those policymakers. But it might be easy, it might be difficult, but it's likely, as most things are, I suppose, to rely on personal relationships and exploiting networks that you have. But I do think that as you engage reliably, it will build. So each time I engaged stakeholders, I had more people than the meeting before, and I had more policy people. So word was starting to get around that this was useful and credible. And I think it sort of builds like that. So I suppose it can be challenging. You probably might need to be quite patient or quite determined in getting the right people in the room. Maybe you'll need to look at finances for that, as we did. I don't know, but it's worth it. Just keep going, I would say. And that thing about that flexibility as well. People will engage with stuff that they know is actually going to benefit their work and make their job easier, but they're not going to just give you loads of free time for something that isn't relevant. So yeah, I hope that helps. I don't know if you had any thoughts yourself or experience of that, Amna?
No, thanks so much, Dr. Naomi. This really helps. And because the first point that I get often stuck into is how to tap into that network. And you very rightly pointed out about leveraging some rapport that has already been built with policymakers. And because I work in Pakistan and in a broader South Asian context, which is why I was trying to get some points that I could replicate from your experience in South Africa to some of the things in South Asia. But thanks so much. Thank you.
You're welcome. Thanks for the question.
Thank you. Dr. Naomi, I was just thinking this question might be related with the reply that just you have made, but as my field of research is actually tobacco, and it actually closely relies with the resembles with the alcohol field, although the context is different as far as Bangladesh is concerned. But I was wondering, when you started doing this, stakeholder engagement and everything, was there already a mapping in place in South Africa for alcohol studies, or you had to develop the mapping by yourself?
I developed the mapping by myself for all the alcohol stakeholders, but there was a really useful paper I found which summarised the alcohol policy process sort of for the last 10 years. So that was incredibly helpful, because it sort of said, this policy came through and then these people protested against it and then these people said this. So that was some of that work had been done. But there wasn't a really clear map. And actually, for me as a PhD student at the time, it was a really useful exercise for me to really start to understand that context. And it is so context specific. I think it's really worth doing and then presenting it and getting people to say, you've missed this or that. So it's quite iterative, and it can really help bring you together as a team. And even presenting that map to your policy contacts and saying, is there anybody I've missed, can be a good way to start that working relationship, I think.
Yeah, I know that there are a lot of participants present today who were in the early career of their research, or they might be aspiring for their PhD as well. So I think it would be really helpful for them if you just tell us a few words on if anybody works in a particular field where there is no stakeholder mapping is done already, or that mapping is missing. So from your experience, is there any tips or suggestions how to develop the stakeholder mapping for those fields? That would be helpful for all of us to know.
Yeah, so sort of different from, I guess I would, what sort of fields are you thinking, Abdullah? Can you give me an example?
So like, for example, I can remember when we started working with the field of tobacco in Bangladesh, there was no actually stakeholder mapping. And currently, I know there were some groups who were working with this sugar and sweetened beverage. And, when they started working, they were struggle because there was no stakeholder mapping in those particular fields. So since you worked a lot in the field of stakeholder engagement, so I would like to know your ideas and process. So if any early career researcher who wants to work, but that field is really underworked and there is no stakeholder mapping, so where to start and how to start?
Yeah. So there's a good reference that gives you an example of how you can go about it, which is in my paper, which we can circulate afterwards as a starting point. I would say international examples can be a really helpful starting point, with the massive caveat that they might be not relevant to your context, but at least it gives you something to possibly disagree with or agree with, rather than starting from a blank sheet. I think it's really important not to speak to people and just provide them with a blank sheet, but actually provide them with a starting point. So I'd say look at international research, particularly if you're interested in sort of anything industry related or commodity related. There's a lot of international similarity and comparison that's available. A lot of these companies operate in many countries, and you'll have international stakeholders. So that can be a really useful thing. Look at the international context and examples, and then think, okay, how does this differ, or how is this similar to my context? And then I would say just start actually getting it down and start sharing that, and start being willing to iterate it and improve it. And then start thinking, who can I talk to that I haven't spoken to before? But generally, I think cold calling probably doesn't work. So you want to try and exploit some networks, but it doesn't take long to get quite big networks if you just sort of go through one. It snowballs quite quickly. So I think it's that, being willing to keep changing it and not being too rigid about it, being willing to learn from international examples, but again, not too rigidly. That and using that paper that, I'm sorry, I can't remember the reference for, but that gives you a nice example.
I have another question from Shojib Shaha in the chat box, and he particularly wanted to know, did you face any challenges to engage the stakeholders in South Africa? And if yes, how did you overcome it, and any tips and tricks to avoid it?
Yeah, so I've already sort of mentioned, so I won't spend ages, but the national policymaker was the hardest to get to, because it felt like the most bureaucratic We had to be very formal, send a formal letter of invitation to him and his boss, and fund flights over. But then also I couldn't provide expenses on the day because it was seen as a bribe, and that wouldn't be okay. So all of that sort of negotiating all of the bureaucracy and getting the time of national policymakers was a barrier. And I would just say, just keep going and get somebody to help you. Don't be a lone researcher trying to do that. I found that getting the highest up person on your side that you could makes a difference, and the person with the most experience. So that was one. The second one was engaging people from the Kailicha Community Health Forum, so these people that lived in informal settlements. When I engaged them face to face, when I was able to go to South Africa, that worked really well. And I was also able to pay their expenses for travel, which was a bit more than they needed for the travel. So it was a helpful incentive. But then COVID happened and we had to do everything online. And then that created a barrier because they did not have such easy access to reliable internet or even space to sit and sort of have the quiet and the focused attention to be able to engage in the online workshops. So that created an issue in terms of equality of access to the research. And what I did with that is I tried to follow up by email specifically to some of my contacts there, because they weren't able to engage in the online workshops, but I was still able to get a little bit of their input sort of slowly via email. So that was a real shame, and I think something to think about, and something to think about particularly with online stuff. There is still a barrier. Tech's great for policy makers, it's great for academics, but it's not so great if you want to engage people who are more disadvantaged a lot of the time. So I think that's really important to think about when you start your research. And the third sort of barrier to engaging people, it was COVID. So, I mean, hopefully, you know, there's turmoil that happens all the time, as we know, you know, as Bangladesh have experienced recently, you know, having COVID, you're always doing your research in a world where unexpected things can occur, and then you're competing with world events or whatever it might be, and people, suddenly your research is not the priority. And I think with that, you know, it's being able to have that flexibility if you can, and come back to things that are important. And a lot of the time your research will continue to be important in the long term, but in the short term it just isn't. So that they were sort of three of the main challenges I found in engaging stakeholders. I'm sure there are many more.
Thank you, Naomi. Thank you for this comprehensive answer. I can see there is another question from Mr. Syed Motoza, and that question is related with the actually industry interference during the stakeholder engagement. And he rightly pointed out that when anybody wants to increase the taxes on alcohol, cigarette, and beverages, and so on, we can see there is a huge resistance from the community, business community, or the industry. So do you have any specific recommendations for overcoming this challenge?
Yeah, this is a massive challenge. I think, and it's really tricky to know sort of engagement or not engagement. Certainly in the alcohol policy area, it was there would be a lot of sort of discrediting of the academics, and like sort of they would get consultants that would publish findings that would sort of say the opposite. So my main sort of approach that I took, and my supervisors recommended, is being as rigorous as you possibly can. So doing research that's good, that scientifically holds up, because you will get found out and pulled apart. I mean, you will anyway, and you can only do what you can do with the data and the methods available, but just making sure your research is as scientifically rigorous as it can be, and that it's as transparent as it can be. So you're not trying to claim that this, like with minimum unit pricing, it's not a golden bullet, it's not going to solve alcohol problems in South Africa. And there are downsides as well as upsides. So classic sort of academic of highlighting all the limitations and the challenges of both, you know, both upsides and downsides to any policy or any research is really important. And just having the research, it's for me, I felt like it's not my job to fight that battle. So I can provide the evidence, and the policymakers or the advocates can take it forward and use it if they want to. But all I can do as an academic researcher is provide the best evidence that I can possibly provide, and then it can be used by them. And I think part of the stakeholder engagement is making sure that evidence is answering the questions that are most high profile in the policy realm. So, you know, if I had not included HIV in my alcohol policy model, it's not as useful for the public health policy professionals, for example. So I suppose partly it's about not taking it all on as a researcher, but also about making it as useful for the current debates as possible, I think. It is a big challenge.
Thank you. Just a supplementary, question with Mr. Syed. We all know that, not all stakeholders behave similarly. And, when it comes to the policymakers, how difficult it is on the part of researchers to bring them on board and, let them speak. It's very difficult to bring the policymakers on board and, do some actions. So I was wondering, how did you, become successful to bring the policymakers on board to do the alcohol research on your context?
So I think I was probably lucky in that they were already interested, or certainly the ones in the Western Cape. They knew they had a really big problem. They experience huge impact in hospitals and crime. You know, it's such a known issue, and they know as a government that they're having to pay a lot out for all of this alcohol harm, and the industry's making them money, and really the government is mopping it up. So I guess it wasn't difficult to get them to engage in the debate. It might have been more challenging to get them to sort of choose a policy or come to what I thought was the best way. But when I started the research, I didn't really have a sense of what the answers were. So it's that flexibility again, sort of, I wasn't going to the policymakers saying, here's a really good policy, and lots of researchers might be in this situation. Here's a really good policy, please listen to my research about it. I was going to them saying, you and I know alcohol is a big issue. I can provide some health economic modelling. Are there some pricing policies that you think might work here? And they were really keen on minimum unit pricing, partly just because it was new and it was novel. And so there was an exciting element to it. Can we be cutting edge policymakers because we'll bring this in and other people haven't done it? So it's like a new answer. I think it would be a lot more challenging if you knew a policy was good, but there was sort of serious policy opposition to it. And maybe with that, you have to wait for your policy window, or sort of just keep providing that really up-to-date, really good scientific research. And then when the opportunity comes, your evidence is there and it can go into that policy process.
Thank you, Naomi. We have got a question from Delali, and he wants to know particularly that how did you engage with stakeholders at the sub-regional level, and how did you do that actually?
What do you mean exactly by that? So in South Africa, we've got the national and then the 9 provinces, and I engaged with one of those 9 provinces and the national level. Does sub-regional mean smaller than that, or do you just mean one of those provinces?
Delali, can you hear us?
Oh, other countries outside of South Africa. That's really useful. Okay. Not for the specific research of the modelling of the alcohol policy for South Africa. I would say, though, that we did engage. So I then went on to do more work specifically for a province, and we did quite a bit of research into sort of international examples of minimum unit pricing in other contexts. So there's an area in Australia that's got a real alcohol problem and they've used it. Scotland in the UK. Russia has some minimum pricing stuff going on. So we weren't engaging stakeholders there particularly, although we did talk to some we did talk to some academics who'd done the work in Scotland and who'd done the work in Australia. So we brought them in on that piece of research because the Western Cape province, really wanted to understand how this policy had worked as a regional policy in other countries. And so we looked, but that was very much desk-based research. We did contact people and have some emails, but it wasn't like the sort of really formal, ongoing process that I've described for mine. I guess it would be, so when I engage stakeholders, I'm always thinking, what's in it for them? Like, how does this improve their work, and how's this going to help? So if you were engaging people outside of South Africa, they'd need to have a really good motivation to give time to the research if it was only going to impact South Africa, which isn't completely implausible. You know, maybe they would like it as an example, and then they're thinking about doing it in their country. But I think with stakeholders, generally, the more local, the better, particularly if you're looking at a national or a regional policy.
So I guess your answers were comprehensive enough and detailed enough to, to address the inquisitive minds here. I would like to just being concerned with the time. So I would just like to thank Dr. Naomi on behalf of HERN and, on behalf of our participants. I believe this knowledge enriching session were helpful for all of us. In fact, for those who are engaged with the applied health research and do this, stakeholder engagement research as well. So you can always subscribe the HERN webinar. All these presentations usually are uploaded at the end of the webinar in the HERN for your future reference. Also, you can email us if you have any query. We can always reach to Dr. Naomi to answer the further questions. Any last words, Naomi, from your side?
Yeah, just thank you for having me, and thanks for those really insightful questions. That was really great. And as just to reiterate what Abdullah said, please do get in contact with me if you have any specific questions. I really welcome that.
Thank you. I would just like to inform you all that this webinar is a regular program that we arrange under the HERN umbrella in collaboration with Center of Health Economics, University of York. Our next webinar is scheduled on 9th of October. Same time. That means 10 a.m. UK time, and the topic would be the economics of mental health. And our speaker at that webinar is going to be Professor Rena Jacobs, who is the Deputy Director of the Center of Health Economics, University of York. So I would like to cordially invite you all and look forward to meet you all in that webinar as well. Wish you very best and healthy life in the coming days. Thank you so much. Thanks, Naomi.
Thank you.
so
Bye,
much.
everybody.
Thank you, everybody. Thank you.